introduction. Thank you so much. So now I call the vibrant, young, and able cornea surgeon, Dr. Aditi Ghosh Dastidar, and she will tell us how to recognize the toxic anterior segment syndrome. Aditi, you unmute yourself. You are muted. Yeah.
Thank you so much, Sumana ma'am, for making me part of this IC. So I hope my slides are visible now.
Yes, your slides are visible.
Thank you so much. So who killed Robin? So I'll be speaking about toxic anterior segment syndrome in this wonderful IC session of water everywhere. So post-op examination day one of an uneventful surgery. So the expectation is not meeting the what we had. We had a good surgeries, a well worked up surgery. Then why the expectation is not meeting? Why post uneventful surgery? We start questioning ourselves. What went wrong? Who killed the Robin? So coming to TASS, an acute sterile inflammation presenting after intraocular anterior segment surgery, previously known as sterile endophthalmitis, post-op uveitis of unknown origin. Then in 1992, TASS, the term was coined. So what is it? It's a reaction to non-infectious substances which enter the eye, causing intraocular cellular damage and extracellular damage. So what are the clinical features? The patient might come with a blurry vision, painless, discomfort, foreign body sensation. The time of presentation is most commonly in the early post-op period, that is within 12 to 48 hours after surgery. Delayed onset has also been documented by Suzuki et al. And Miyake et al. So what are the most common clinical features? In anterior segment, the classical limbus to limbus corneal edema is seen, fibrin formation, hypopyon, irregular or fixed pupil. Intraocular pressure is only in early cases it is decreased and followed by a higher rise in intraocular pressure in later days. Post-op segment involvement depends on the severity of TASS. In vitreous, we can see spillover inflammation. In retina, mainly in cases of IOL toxicity, there can be retinal toxicity. Persistent CME and in choroid, transient choroidal thickness increase on OCT has been documented. So what are the causes of TASS? These are all the causes which have been reported. So mainly whether it is the OVD solution, cleaning solutions on IOL, balanced oil solution, preservative, antibiotic, intravitreal injection, or intraocular anesthetic. All of them have a common pathway. Not to forget autoclaving, ultrasonic baths, powdered gloves, ointment application, intraocular dye application, and enzymatic degradation. So what is the common pathway? Cellular toxicity of the chemical agents, free radical, that is hydrogen peroxide present in the ophthalmic preparation, generate an oxidating stress, forming free radicals. Blood aqueous barrier breakdown caused by this inflammatory triggers. So one of the most dreadful differential of TASS, every ophthalmologist's nightmare, is it ENDOF? Why is it important to distinguish? Because the course and complication of ENDOF are very severe and there's a fundamental difference in the treatment of the two. So the dreaded differential diagnosis itself, most commonly posterior segment involvement is more severe in ENDOF, the time of presentation is later, and microbiology, negative cultures for bacteria and fungi, negative PCR is found. Good response to topical steroid treatment, these are seen in TASS, whereas a good response to intraocular, intravitreal antibiotic is seen in ENDOF. Other differential diagnoses have been wonderfully covered by the previous speakers, but still prolonged surgical time, intraocular manipulation, Dismet membrane detachment, remnants lens material in AC very easily missed, any hemorrhage from the limbal vessels during the incision, or reactivation of an uveitis. We might have forgotten to take a history of herpes and that might have reactivated. These are all other differential diagnoses. What are the complications or long-term sequelae? Depending on the corneal endothelium damage, it can be just transient corneal edema resolving to steroid or a long-term persistent edema requiring surgeries in the future. Epithelial downgrowth, which is a cystic epithelial downgrowth onto the DM, can be seen. Secondary glaucoma caused by the fibrinous membranes and trabecular damage can be seen as well. So in the management, prevention is always better than cure. There are multiple guidelines for correct cleaning and sterilization of intraocular ophthalmic instruments. We should abide by that. And so the aim is to decrease the inflammation. So topical steroids, subconjunctival, all depending on the severity. Topical NSAIDs can be used, but we have to avoid prostaglandin analog. IOP lowering agents, AGM, have to be used if there is a spike in the IOP. Some refractory cases do require intracameral injection of recombinant tissue plasminogen. Surgical, depending again upon the severity and etiology of the inflammation, irrigation of the anterior chamber, removal of the IOL causing the TASS, vitrectomy, and as I mentioned, endothelial keratoplasty or PK if there is an corneal decompensation in the later stages. Also glaucoma surgeries if there's secondary glaucoma. So to conclude, it is very difficult to prevent because it has a multifactorial etiology. If untreated, it can cause devastating complications in the future. So early recognition is the key. And vigilant surgeon and OT staff and also case reporting in TASS cases is very important. So just to take home message, we have to be, so the surgeon's eyes have to be open. We have to listen what is going on in the OT, even while we are operating. A very supportive, vigilant OT staff is required, and an early detection of TASS on our post-op days without thinking. We have to act as fast as we can. Thank you so much. These are the references.